This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, a senior attending in neurosurgery.
And I'm Dr. Ilara, a research fellow. Today we're looking at a fascinating new study from the Chinese Journal of Reparative and Reconstructive Surgery, titled Research Advances in Nerve Transfer for Upper Limb Function Restoration, Applications from Peripheral Nerve Injury to Central Nervous System Injury.
This is a timely review, Ilara. For decades, we've looked at nerve transfer as a peripheral solution for peripheral problems. Think brachial plexus avulsions. But this paper highlights a paradigm shift, moving from peripheral repair to inducing central plasticity. We're now using these techniques to treat spinal cord injuries and even hemiplegia from brain injuries.
Exactly. The paper starts by reminding us that over 90% of tetraplegic patients believe that restoring hand function would most significantly improve their quality of life. Nerve transfer is essentially the surgical rerouting of healthy, redundant nerve fibers, the donors, to the distal end of a damaged nerve, the recipient.
Right. And while the microsurgery is the bridge, as the paper calls it, the real magic happens in the brain. They cite Lundborg's 2000 theory that the hand is an extension of the brain. When we move a nerve, we aren't just moving a wire, we're forcing the somatosensory cortex to remap itself.
Let's break down the applications starting with what we know best, peripheral nerve injuries, PNI. The paper categorizes these into ipsilateral and contralateral transfers. For ipsilateral, the gold standard mentioned for restoring elbow flexion in upper trunk injuries, C5 and C6, is the Oberlin procedure,
Which, for our residents listening, involves moving a portion of the ulnar nerve fascicles to the motor branch of the biceps. The paper notes its success is due to the short regeneration distance and the synergistic nature of the donor and recipient, which makes cortical remodeling easier.
But what happens when the entire plexus is avulged? The paper highlights the work of Professor Gu Yudong, who pioneered the contralateral C7 or CC7 transfer in the 1980s.
That was a game changer. By using the healthy C7 from the non-injured side, we can bypass the entire damaged plexus. The paper mentions a shift from long grafting to the direct anastomosis via the pre-spinal route, which has led to about 62% of patients achieving M4 finger flexion strength.
What I found most interesting in the PNI section was the deep dive into the brain's response to CC7. The paper describes a three-stage dynamic reorganization: ipsilateral, contralateral, ipsilateral. Initially, the injured limb's movement is controlled by both hemispheres, but eventually control shifts back to the original motor area of the injured side.
That one brain controlling two sides concept is what paved the way for treating central nervous system injuries. Let's shift there. How is nerve transfer being used in spinal cord injury, SCI?
In cervical SCI, specifically C5 to C7 injuries, the goal is to bypass the short circuit in the cord. We use nerves innervated by segments above the injury to restore function below. For example, transferring the nerve to the supinator to the posterior interosseous nerve to restore finger and thumb extension.
It's a brilliant strategy. It converts a central spastic paralysis into a peripheral reinnervated state. But the paper points out that the effectiveness in SCI isn't just about the connection, it's about activating the plasticity of the spinal cord distal to the injury site.
Which brings us to the most provocative part of the study: brain injury and hemiplegia. Unlike the flaccid paralysis of a peripheral nerve injury, stroke or traumatic brain injury leads to complex spastic paralysis.
This is the frontier. The paper discusses using the CC7 transfer, taking the C7 from the healthy side and connecting it to the paralyzed side to treat this spasticity. The results show a significant reduction in muscle tone and improvement in some motor functions.
But there's a catch. The paper is very honest about the limitations. While we see better gross movement, fine motor skills and key muscle strength in the hand remain limited. Patients often struggle with coactivator nest patterns or joint movement modes.
Let's dive deeper into why that is. Why does CC7 work differently in a brain injury compared to a brachial plexus injury?
The study suggests it's a matter of maladaptive plasticity. In a brain injury, the interhemispheric balance is already disrupted. The paper cites a recent study from Hashan Hospital showing that CC7-mediated recovery might actually go through the cortico-red nucleus spinal pathway rather than the traditional corticospinal tract.
That's a crucial distinction for our neurosurgery residents. If the recovery is mediated through the red nucleus, it explains why we see better gross coordination, but struggle with the high-level fractionated finger movements that the corticospinal tract usually handles.
Exactly. And there's the issue of synechiasis, or mirror movements. Because one hemisphere is now trying to control both hands, the patient might try to move their healthy hand and have the paralyzed hand move involuntarily. The paper calls this the challenge of functional competition between the two sides.
So where do we go from here? The paper concludes with some future directions. It's not just about the surgery anymore, is it?
No, the authors argue for a multimodal approach. They suggest combining nerve transfer with cell or gene therapy to enhance axonal regeneration and electrical stimulation to promote plasticity.
They also emphasize systematic rehabilitation training. We can't just do the surgery and walk away. The brain needs to be taught how to use this new wiring. The paper notes that current applications in brain injury are still limited by a lack of surgical diversity.
Right, we're mostly just doing CC7. We need more donor-recipient combinations tailored to the specific patterns of spasticity and loss of function seen in stroke patients.
To summarize for our listeners, nerve transfer has evolved. It's no longer just about bridging a gap in a peripheral nerve. It is a tool to induce central remodeling. Whether it's PNI, SCI, or stroke, we are essentially hacking the nervous system's innate plasticity to bypass permanent central damage.
It's a shift from peripheral repair to central modulation. While we've mastered the bridge in peripheral injuries, the challenge in CNS injuries is managing the remodeling to avoid maladaptive patterns and restore fine motor control.
Fascinating stuff. That's all the time we have for today. Thank you, Dr. Ilara, for walking us through this.
My pleasure, Dr. Aris.
And thank you all for tuning in to the Neurosurgery Hub podcast. Stay sharp, and we'll see you in the next episode.